Hi, I'm Dante Mendoza, and today I'll be presenting humerus fractures. I had an issue with trying to get my camera to work. It doesn't work on my Chromebook, and the external webcam that I had doesn't work with the software that I have, so I'm sorry for that. But I'll still present anyways. So we have the types of humerus fractures: proximal humerus fractures, shaft humerus fractures. Two types, very simple. And we'll get into the anatomy of it. So first we have the humerus joint or humerus, which is the bone that we will be talking about. It's right here. Um, the scapula is here. Here is the clavicle, and there's the GH joint right here, known as the ball and socket or shoulder joint. And this joint is where the humerus head is located, and the anatomical neck and epiphyseal line of the humerus, and this is where the fractures tend to occur for a proximal humerus fracture. Then, as it gets narrower and starts to not widen, get smaller, narrow, you get the humerus shaft, and then it widens out down towards the bottom when you get the epicondyles, the lateral epicondyle and the medial epicondyle in the capitulum and the trochlea. Those connect to the radius and ulna in your forearm part. So that's the humerus. That's some basic anatomy, and that's what we will be talking about. So etiology: proximal fractures and shaft fractures. They tend to occur from small blows or falls. That is, proximal fractures tend to occur from falls and small blows. And most of these injuries are not displaced. 15 to 20% are displaced, so 80 to 85% are not displaced. That means no subluxation or dislocation. Some common symptoms are shoulder pain, difficulty moving your arm and shoulder, and then bruising and discoloration. And etiology for shaft fractures, pretty simple stuff. You got three types of fracture patterns: transverse, oblique, and spiral. Falling may cause these injuries. Say you fall from a tall height, from high up, onto your arms. Let's say you're dunking a ball and you're moving, or you jump and you land, you put your arms out. Just high energy injuries. And a typical high energy injury that could have a shaft fracture is a car crash. So there's many places the bone could break. It could break towards the head of the bone or towards the bottom, the butt of the bone, one would say. And there's three patterns. Some common symptoms are pain when moving the arm, swelling, or bruising. So now that you know what type of injuries there are, how they occur, let's look at the treatment. So there's two routes for treatment, and it doesn't matter if you have a proximal or shaft. Treatment methods are typically the same. So there's locking plates if you're surgical or operative. Locking plates are one surgical technique that are used. Non-surgical technique is bracing, and with bracing, there's also slings, so that could be used in locking plates. It could be a sling also, and that is typically used for 4 to 6 weeks, depending on what your doctor feels like, telling you whether or not you can take it off or not, based on how you are improving and healing. And now we have rehabilitation. So after you get treatment, you gotta recover, right? So in order to get a good recovery, ROM is necessary. So here displayed are three basic ROM exercises that can be performed. You got flexion, hyperextension, abduction, adduction, outward rotation, and inward rotation. Now, with all of these range of motion exercises, they all can have restriction and turn into restrictive range of motion exercises, restricted range of motion exercises, and that can help you strengthen. So an arm can be placed on the shoulder of the patient, and an arm will be placed trying to restrict that movement. So for flexion, on top of the forearm as they try and flex their arm all the way up in a straight on position, and then extension, you just flip it over. Same with abduction, away from the body, adductions toward the body, outward rotation and inward rotation, limiting the movement with somebody giving some restriction. And with that, outward rotation and inward rotation can also be called lateral rotation and medial rotation. And you can do that with your arm placed at a 90-degree angle at your side. Medial is towards your stomach, lateral away. Some more rehabilitation exercises are bent elbow to straight. Pretty simple, explained by the picture here. You have a bent elbow with your palm facing sideways, not supine position, halfway pronated, right, in a neutral rotation, and you just straighten out your arm. And then forearm rotation is quite literally going from neutral rotation to full pronation, or from full pronation to supination, and then other way around. That's pretty simple. But in conclusion, just need more data and research in general. Right now, we're at the tip of the iceberg here. We know good, we feel like we know a lot, but we really don't. And in most of the research articles about this injury, they talk about how it's not very common, so there's not very many cases amongst athletes, and typically there are preferred methods like the locking plate or maybe the brace or typical range of motion exercise that are preferred, but nothing is considered the best method or way to go about things. They all say that there's not enough data and there just needs to be more research and evidence to back up these claims. If there are any claims out there, there hasn't been too many research articles stating percentages, as there's just not that much out there. So that is my conclusion. Here's my reference list. Thank you.